Good morning, everyone, and a warm welcome to our annual health talk organized by the Limapin Road Church of Christ. My name is Eunice, and I'm a member of the Limapin Road Church of Christ congregation. On behalf of the organizing team for this year's health talk, we thank you all for your attendance today. This is the program for today. So our first speaker will be Dr. Nicodemus Wee, who will be sharing on the topic of neck pain. Our second speaker will be Dr. Joelle Lee, who will be speaking to us on the topic of knee pain. And our final speaker, Ms. Kelly Chu, will be sharing with us practical tips on neck and knee pain management. During the break, please help yourselves to light drinks and snacks at the kitchen area at the back. There is also a Q&A segment at the end of the three talks, so do keep your questions until the end for the speakers to address. Like what I mentioned earlier, if you wish to write down your questions so that they can be passed to myself during the break or at the Q&A segment, you may help yourself to the slips of paper and pens at the back of the hall during the break later. So to kickstart our event, I'm pleased to introduce our first speaker, Dr. Nicodemus Wee, who is also a member of the Limapin Road Church of Christ. Nicodemus graduated from Duke NUS Medical School in 2015 and currently works as an associate consultant in the Department of Physical Medicine and Rehabilitation under the NUHS system. He often takes care of patients with neck and back pain and is also involved in clinical and translational research work in neurorehabilitation, brain stimulation, and stem cell therapy. We look forward to hearing him share on neck pain, what causes it, and how do we make it better.
Thanks, Eunice. Hi, everyone. Wow, so good to see everyone here on a public holiday. As mentioned, this is the Limapin Road Church of Christ organized seminar, and we're here to answer any questions you may have. And we are so glad that you came here to understand more about these conditions. Why we chose neck and knee, where people have back, and maybe I heard someone has hip and ankle pain. We hope that from the sharing today on neck and knee pain, you'll be able to garner some principles that you can apply to any sort of pain. But just to get us started, I'll open up with a discussion of neck pain. So how common is it? How common do I hear the complaint, doctor, my neck hurts? It's very common. Okay, so it is estimated that up to 18%, or so 1 in 5 of the population throughout their lifetime will experience some sort of neck pain. And it's getting more and more common nowadays with us, with a lot of us being on the screen a lot, reading, looking at the computer monitor, having our head kind of like bent forward without realizing it for long periods of time. In the young, well, we have people who are doing video games, playing video games, and getting text neck, which is very common in the young population. And it's also estimated that in fact, 1 in 3 may develop incidents of neck pain in lifetime, and it's more common than low back pain, in fact, which is contrary to most people's beliefs. The good news is that the vast majority of these neck pains and neck aches will get better with conservative treatment. What do I mean by that? Rest, stretch, a bit of exercise, warm pack, cold pack, it should get better. But in order for us to understand what causes it and for us to be able to prevent it, we need to dig a bit deeper. And I hope you'll be with me as we now go into the in-depth look into the neck and what is inside of our necks. So if you can imagine our heads, the average human head is about 5 kilograms in weight. That's more than the weight of a 3-month-old baby. Has anyone ever held a 3-month-old baby before in their arms? After hours and hours, your arm starts getting sore. And that's because 5 kilograms is pretty heavy. Now, the head, which contains the brain and all the bones of the skull and everything, is suspended on a stick, which is our neck. But this stick is very flexible, being made up of different bones, as you can see from here. There are 7 bones in total, and each of the bones are connected through what we call discs. Okay? And this allows the neck to flex, to extend, to bend, and to turn. Okay? It's quite an amazing structure that God has made, and this allows us to do every single activity that you can think of, from chopping the vegetables, you have to look down, to typing on the computer, to looking to see where your son or daughter is, looking over your shoulder when you're driving, checking your blind spot. Every single one of these activities puts stress on the structures of the neck. So what are the structures of the neck? Besides the bones, which we cannot really control if we didn't have any muscles, we have the muscles. So the muscles, some groups of them are on the back to extend our neck backwards. Some groups of them are on the front to flex our neck downwards. And there's muscles on either side that turn the neck. And these muscles, if they get overused or they are imbalanced in any way, they will cause pain. They themselves can be a source of the pain. Notwithstanding the bones and the discs in between the bones. Then there are the nerves as well. In our necks are nerves that come out of the holes on the sides of the bones of the neck that go into our arms and our hands and our fingers, controlling them and being able to move them. And if these get pinched in the neck, you can have neck pain and hand pain and arm pain. Very common, right? So that we call that nerve pain radiculopathy. Radiculo means roots. So there are roots of the nerves that come out of each side of the neck bones, the holes of the neck bones called the foramens. Never mind the medical terms, but basically the nerves then go into our arms, right? Of course, the neck itself is housing the spinal cord. And unfortunately, in some cases, this can get damaged from falls and such, causing paralysis. So that is what we don't want to happen to us, right? Because the neck is at the top, and it's like above our arms and our legs. Any damage to the neck can cause paralysis of the arms and the legs. And many of my patients, unfortunately, have that. And they can't walk, and they can't pee and poop. That's because all the nerves that control these functions are also housed in the neck. Okay, so now, in summary, any structure, whether it be bones, the disc between the bones, the ligaments that hold the bones together, the muscle that moves the bones, all can cause pain. Now, why? I mean, how do we arrive at this diagnosis? Well, we as doctors, I'm a rehab doctor, Dr. Joel Lee is an orthopedics doctor, Miss Kelly Chu is a physiotherapist. We all work as a team to arrive at diagnosis, but we can sort of divide pains into acute, less than 6 weeks, subacute, and chronic, which is more than 12 weeks. The point here to note is that if at any time you experience neck pain that's lasting more than 6 weeks, you do need to be seen by a medical professional, one of us, okay? That is the gist of this mess of text, which basically says that if it's acute, less than 6 weeks, short duration, you can try conservative treatment. Cold pack, ice pack, stretching, and you will see in the third talk that Ms. Kelly Chu will help us, introduce us to some of the exercises that can be done, some practical tips into the management, okay? But anything longer than 6 weeks, where in between 6 to 12 weeks, you can still have a chance that it's just muscle sprain, maybe a little bit of bony ligamental injury that can potentially heal. But anything longer than 12 weeks, please don't wait anymore. Make a call to one of your friendly doctors. Now, on this topic, there are some things that we all need to learn here. If we leave here, this session, knowing one thing, it is that if you encounter any of these red flags, please do not delay any further. Come to see the doctor. The emergency department, in fact. So that would be if you have unexplained fevers and neck pain, if you have balance dysfunction, you fall a lot suddenly where you never fell before, you are unable to find a comfortable position, if there's trauma, if you've been involved in an accident, and you have neck pain subsequently, or any of these other red flags, do be alert that more detailed investigations, including a CT scan and MRI scan to look inside the neck, may be required. Now, just a very short, brief introduction of how we doctors arrive at a diagnosis. So if you were to come to us, what do you expect? We would then try to distinguish whether your pain that you're having is something related to axial structures, and that means in the center, in the bones of the spinal cord, the vertebra, or whether it's these nerve roots that I was telling you about that go into the arm, whether that is causing the problem. Because depending on which one of these you have, the interventions, the potential medications that we can give, the injections that we can offer will be different. Okay? At the most basic level, we can prescribe some lifestyle activity modifications, exercises, stretches, and short-term relief, like I mentioned, with cold and hot packs. But in more severe, more refractory cases, we may be able to offer some injections, which we do as well on a day-to-day basis. Of course, when it gets too bad, surgery may be offered, but this is to say that actually surgery is actually a very, very small subset of the population, not to worry, okay? Now, the other way that we can tell, and this is something that you can do at home, we can share this with you later, or you can feel free to take a photo. This is something called a neck disability index. So what do I mean by that? Any of these conditions that cause pain, whether it be neck or in the knee or the back, right, can cause someone to become unable or less able to do their activities, whether it be taking care of the children, working in an office, or something as simple as sleeping. If the neck pain bothers your sleeping and you can't sleep because of the neck pain, then something's got to give. So this scale, which you can do by yourself, in fact, can then quantify how severe the neck pain is and how disabling it is in your life. And based on this kind of information, we doctors can then also make a conclusion or a recommendation as to whether you need to undergo further tests or whether this is something that can just be treated conservatively, right? So the scores range from mild, moderate, severe to completely disabling. So in the final part of the talk, I just wanted to go in depth into what causes the neck pain that we've just mentioned earlier. And the takeaway here is there's one posture that everyone here at the end of this meeting should know about, and that is this forward head posture. You can see that the ideal case is on the right here, where this lady is almost like perfectly postured, so sui, like very beautifully sat down and with all the angles at 90 degrees and the head straight. This is what we want. But the reality that we face is that a lot of us are doing this, like this skeleton man over here, where our heads are often here like that without us even knowing it. And I can show you even right now, right? If I'm texting, if I do this, if I do that, I go more and more and more. Eventually, what happens is there's something called the upper cross syndrome. And it is where the muscles at the back of the neck, the upper trapezius at the back of the shoulders, the beta scapula, become tight and overworked because you're always constantly head forward. And our chest muscles, which is directly crossed from that upper back, again become tight and become very compressed. And that leads to this rounded shoulder posture as well, as you can see here, right? That's bad because what happens is the other opposing side, so the front of the neck, where the muscles that Kelly will be showing us later are responsible for moving the neck forward, and the back of the lower back, which is the rhomboids that pull our shoulder blades together, that becomes weakened. So what we have is a situation where this side of the cross is too strong, too tight, and this side of the cross is too weak, as you can see from here. Okay? This is upper cross syndrome, and this is one of the major, if not the major cause of neck pain. So it leads to rounded shoulders, hunch forward in the trunk, loss of normal curvature of the neck. What do I mean by that? The normal curvature of the neck is slightly bent to the back, but if we lose that and the neck starts becoming straighter in terms of its bony alignment, then we run into problems. The nerves may be pinched, the ligaments may be torn, the muscles may be stressed, right? And that leads to pain. A lot of people say, oh, I have neck pain, why are you fixing my shoulders and my back? But they are all connected, see? So that's why it's important to know what posture contributes to neck pain so that we can fix it. So how do we fix it? Well, before that, just to share, okay, somebody did a study in 2014 where, as mentioned, the head weighs about 5 kilograms, right? But if you were to put your head forward just even 20 degrees, the weight of that head, the force of that weight through the lever arm on the neck is upwards of 22 kilograms. So that is the equivalent of 39 basketballs and 1,115 sushi rolls, okay? That's how much force your poor neck has to suffer through if you were to constantly do that. So we don't want that. But what are some other myths about neck pain? So just to reassure you, although these postures and these bad habits can cause neck pain, it is not true that you will require surgery. So only, just to reassure again, severe neck pain, only less than 5% of those people eventually will require some sort of surgery. But let's say, even if it's severe or if it's moderately severe, acute episodes, as I mentioned before, do not really need CT scan, MRI scan, okay? Not to worry. As the neck and the spine ages with you, as you age, things can start to have wear and tear, and aches and pains are quite common. Despite what you may read online, there's no such thing as a perfect pillow. Okay, so maybe that answers most of the questions already. There is no such thing as a perfect pillow, but there is something that's overly extending your neck and inadequately extending your neck. So we don't want anything extreme. Something in between that maintains like a normal curvature of the neck would be useful. Braces, like collars like what that lady is wearing on the right, not very useful because firstly, it looks bad, it's hot, and it impedes movement and actually weakens your muscles, so we don't want that. Popping or clicking can be alarming, but it doesn't mean anything. Okay, no need to worry about that. And it's also important to understand the difference between hurt and harm. So you go and play soccer or football, you may hurt yourself, but that may not cause irreparable damage, which is harm. Okay, so meaning to say, please go out and enjoy yourselves, play sports, engage in physical activities. So I'm not going to try to do too much here because Kelly will be going in depth into the management and the practical tips. She is the physiotherapist. We work closely with physiotherapists to deliver the exercises, treatment. But I just wanted to bring forth two things that you can even do now as you're sitting here. And the first thing that you can do to fix this upper cross syndrome is called the suboccipital stretch. So the suboccipital muscle is, the occiput is the back of the head. Suboccipital means below the back of the head. And that's the muscle here at the back that is often very tight and very compressed because of this posture, right? So we can stretch that by doing what this gentleman here is depicting, where you're just seated and you're just trying to press your chin and hold the back of your head and kind of pull the back of your head gently and press your chin downward like that. So you can do that now actually and see whether that has some relief. Most people would say, oh, actually by doing this alone, I have some relief. But don't get your hopes too high. And you'll look forward to Kelly's talk later and Joel's as well. This can be done centrally, so that would treat both the suboccipital muscles, left and right, or you can skew it towards the right or the left, depending on where your pain is. Okay? So that's one thing. So that stretches the neck extensors. That is so poor thing. That's holding the weight of the head on the shoulders. The other thing is something that you can do when you're lying down, or actually even when seated. So Kelly just shared with me that she actually prefers to do this while seated. And that is a chin tuck or a neck flexor strengthening. So instead of stretching at the back of the head here, right? The goal here is to strengthen the deep neck flexors that kind of get weakened from our text neck posture. And all you're doing here is just kind of tucking your chin, like making yourself have a double chin against resistance. You can apply resistance with your hand, or you can just do it like that, okay? And as you do this, you strengthen the neck flexors, this guy here, right? And kind of balances out the force between the overly tight upper trapezius and the weakened neck flexor. Those two things, the suboccipital stretch and the deep neck flexor, is something that you can do even while seated when you're taking a break from your work, you're seated there, nothing to do, playing games. Just do a few stretches. You can hold it for 10 seconds, rest, hold it for 10 seconds, and do 10 times. That will help. But again, this is just to whet your appetite. More will come during the next few talks. So with that said, posture is a huge, huge thing that when it comes to pain of any sort, whether it be in your neck or your back, posture is everything. And that means avoid the picture on the left. Try to maintain a posture closer to the picture on the right, where the check mark is, to prevent and combat this epidemic, which is the upper cross syndrome. Without realizing it, without knowing it, this is becoming an epidemic, and unfortunately, we're seeing more and more patients complain of neck pain just because of something so fixable like this, right? So the idea is to maintain a neutral spine. What does that mean? That means the spine, which is it extends from the bottom of the head all the way to the tailbone, it should be kept as neutral as possible. That means not like this, and not like this, but neutral, okay? That means the hips also have to be level. The shoulders should be square, not like that, not like that, okay? The cervical means neck. Cervical protraction means not like this, but like that, as much as possible. So double chin is actually better. And the shoulder blades, not like this, round it like that, but retract it, and the shoulder blades are actually together. Imagine if there's a pencil in between your shoulder blades and you're trying to squeeze that pencil. That's what you're trying to do in an exercise manner, but in a normal posture, just maintain it as relaxed as possible, as neutral as possible. And with that, I would like to thank you, and just to inform you that the next few talks are going to be even more useful and informative. So do stay back and do ask us questions, any of them you may have. We are a church that meets here in this very building every Sunday. You're welcome to join us. Or if you're living in the East, you can join Dr. Joel Lee at 63 at Ubi. Thank you.
Thank you very much, Nicodemus. I'm pleased to introduce our second speaker, Dr. Joel Lee, who is a member of the East Side Church of Christ. Joel graduated from the Yong Loo Lin School of Medicine, NUS, in 2014 and currently works as an associate consultant in the Department of Orthopedic Surgery at Ng Teng Fong General Hospital and National University Hospital. He practices primarily in the area of foot and ankle surgery and has an interest in minimally invasive and arthroscopic surgery in the areas of deformity correction, degenerative conditions, and sports injuries. We look forward to hearing him share on his topic, Doctor, Why Do My Knees Hurt?
Okay, good morning all. It's a pleasure to be here this Wednesday to share with everybody. So like what Eunice has so generously introduced, my name is Joel and I am a Christian and I worship in Eastside Church of Christ. My day job, however, is being a doctor, and like she said, I practice at Ng Teng Fong General Hospital as an orthopedic surgeon. So I primarily specialize in the area of foot and ankle surgery, but I also do know quite a bit about knees as part of my training. And today I'll be sharing with you all about knee pain. Why do we have it, what you can do about it, how we can prevent it, or at least slow down its progression. Okay? So the outline of today's talk, first up we'll be looking at why this topic was chosen and its relevance. Next, I'll be sharing with you common causes of knee pain through looking at the various structures in the knee joint. And after that, I'll be highlighting some characteristics of knee pain that may be more serious or may warrant a consultation with a general practitioner or even a specialist. And the fourth item on the agenda would be really to explain or rather demystify what osteoarthritis really is and what treatment options there are available for this condition, and going through some frequently asked questions, questions that perhaps you always wanted to ask your doctor but never had the time to. Okay? So now the disclaimer here is that some of the answers and some of the information here are based on my own practices and some of the institution guidelines, and this may differ from institution to institution and their recommendations as well. So first question, why knee pain? Why are we talking about knee pain today? Well, the short answer is that knee pain is extremely common, okay? It's a problem that affects both the young and the old, and one that probably has affected everyone in the audience, including myself. In fact, in a cross-sectional study of 500 plus Koreans aged 50 and above, it was found that the prevalence of knee pain was almost 50%. It was 45%, and it increased with two things, with age and more common in women. Okay, so for the women out there in the audience, sad to say you are more likely to have knee pain. Okay, so yes, if your knees hurt today, you're probably not alone. Okay, the next reason for talking about knee pain today simply is because knee pain is very functionally limiting. The truth of the matter is we need our knees to walk, we need our knees to climb stairs, just the 2 steps that I took over here to come to this rostrum. We need our knees to run, and having knee pain restricts one from participating in many of the things that we like to do. Okay, things like even just going to the market, doing household chores, although that's not something we like to do, but it's essential. I can personally attest to it because I once tore my right knee anterior cruciate ligament, and I required surgery to reconstruct it. And during my rehabilitation, I could not put weight on my leg because I had a meniscus injury. So I could only get around on crutches and a wheelchair. And I must say that experience is very humbling, and experience is something I do not want to go through again. Okay? So in fact, in the same study of the Korean elderly population, it was found that patients with knee pain fared up to 5 times worse on functional scores. Functional scores are where they measure their speed in which how fast they get up and walk, maybe just 20 meters. So patients with knee pain fared 5 times worse on this scoring system compared to those without knee pain. So knee pain is unpleasant. Okay, so that's why we're talking about it. The last reason is I think many people have several misconceptions about knee pain and its causes. Should I take calcium? Is it rheumatism? Do these injections work? When do I need a knee replacement? So hopefully I try to answer, I may not answer all these questions, I try to answer some of these questions today through this talk today, okay? So before we talk about causes of knee pain, I think it's important to briefly understand what makes up the knee joint, okay? So I'm not going to go into detail, I'm not going to teach you an anatomy lesson, but rather we're just going to highlight some of the key structures, key parts of the knees. Okay, so the knee joint is a modified hinge joint, okay? So what's a hinge joint? So the doors that we have, the doors that open and close, those are hinges. So it's a modified knee hinge joint because it mainly does 2 main actions. It bends and it straightens. Okay, there are other side actions that it does like rotation, slight translation, but not so important in the day-to-day activities of the knee. The knee joint, most of us think of it as articulation between, or movement between 2 bones, the thigh bone and the shin bone. Okay, the thigh bone is called the femur, the shin bone is called the tibia. But there's also another bone in front of the thigh bone called the patella, or what we call the kneecap. Okay, and that's important in knee extension movements. So to allow the joint to move, the articulating surfaces, or where the joint is, you imagine the hinges that you have for the doors, they need to be smooth or so that they can bend. You need to oil it regularly. So similarly, for the knee, the articulating surfaces are smooth. And how they smooth? They're covered by this thing called cartilage. And they allow for near frictionless gliding and movement. Okay? So in this picture, this is the whitish area that you see over there, okay, that covers the front of the knee. This is the cartilage. So to allow the joint to move stably, so for example, you have a door hinge, but you only have 1 hinge. When you open and close the door will move in various positions, the door will get stuck, it won't move stably. Okay, so to allow the joint to move in a stable manner, means in a very controlled manner, we have these things called ligaments. Okay, so ligaments are soft tissue structures that prevent abnormal motion of the joint. Okay, so in the knee, we have 4 main ligaments. I mentioned one that I taught, which is the anterior cruciate ligament, is the one seen in front. Okay, we have 2 at the side, called the medial. Medial means the inner, lateral means the outer, and then we have 1 at the back, called the posterior cruciate ligament. Okay, so don't need to care about the names. Essentially, these ligaments prevent abnormal motion. Lastly, to allow the joint to take increased load. So what do I mean? For example, you run a lot, you put your weight on the knee a lot when you walk. The cartilage will wear out easily. So how God designed it is that, instead of just the cartilage bearing all the weight, there are 2 things that help to bear the weight, and they're called the meniscus. Okay, so there are structures that improve the load-bearing capacity of the knee, and we have 2 of these, one on the inner side and one on the outer side. And lastly, to allow the joint to move, we have muscles and tendons that help to straighten and bend the knee. Okay, so certainly there are many more structures that make up the knee, but this is the gist, and I think knowing this will help better localize the cause of one's knee pain. Okay, so causes of knee pain can broadly be divided into a problem, okay, with any of the structures that I mentioned earlier. Okay, so number 1, the bone. Number 2, the cartilage. Number 3, the meniscus. Number 4, the ligaments. Number 5, tendons and muscles. Okay, of course there are exceptions, things like referred pain from the hip, from the spine, pain due to cancer. But by and large, most knee pain is due to a problem in one of these structures. So it's impossible and fairly unhelpful for everybody out here for me to just list down all the causes one by one. So I'll be just picking the top few causes of knee pain in the adult population. And a review article in 2023 listed 3 things as the top causes of knee pain in the adult population. The first one, as all of you will expect, would be knee osteoarthritis. Okay, I'll go into detail what this is, but essentially this is wear and tear of the knee, this is degeneration of the knee. Okay, the second top cause is patellofemoral pain, and the last is meniscal tears, okay, or ligament injuries. So in general, if you're above 45, for those above 45 in this audience, knee osteoarthritis is the most likely diagnosis that you have, while in patients below the age of 40, patellofemoral pain, okay, is the most likely condition. In the setting of an injury, for example, you're playing soccer, basketball, when you twist your knee, then more likely you're going to get meniscus tears or ligament injuries, okay? So I'm just going to share a little bit, a brief gist about each of this, okay, so they can better understand. So number 1, knee osteoarthritis. It's a problem with the cartilage, okay? It's a problem with the cartilage, okay? Why that happens, we don't 100% understand. It's a combination of aging, combination of genetic reasons, combination of weight, combination of alignment issues, but essentially all this leads to a loss of cartilage. And this loss of cartilage leads to exposed bone coming in contact with exposed bone on the other end. So this exposed bone have nerves connected to it. So when bone and bone rubs against each other, okay, they cause pain because of abnormal loading. Okay, and what happens with absence of cartilage? Remember the analogy of the door. If your door is not well oiled, it can't move properly, so you get a lot of stiffness because there's no more normal gliding motion and no more smooth surfaces for the knee to move. So you get a lot of stiffness, and that's why many people with osteoarthritis, they are unable to squat, they are unable to climb stairs. Okay, so since osteoarthritis is so common, I'll be talking more about it in one slide later on. Okay, so moving on to patellofemoral pain. This is a very fancy name, but essentially what you're talking about is anterior knee pain or front of the knee pain. Okay, and this knee pain is something you get when you do things that activate your thigh muscles. Okay, so for example, things like stair climbing, going up and down stairs, or going up and down slopes. This fancy name, patellofemoral knee pain, or we call it anterior knee pain or front knee pain, it's a problem that has many causes, resulting from cartilage issues on the front of the kneecap, to tendon problems, muscle weakness or muscle dysfunction, to even alignment issues. But the end product is usually an overload. So there's an overload of the cartilage in the front of the knee, okay, and the thigh bone, and this results in pain. So how is this addressed? How is this treated? Most commonly, although there are some surgeries to address it, most commonly this is treated non-surgically, okay, with physiotherapy to strengthen the muscles and the side of the knee. Okay, we call it the vastus medialis, but essentially one of the thigh muscles that help to stabilize the kneecap, and with painkillers or modification activity. Just stop climbing stairs and then you don't have knee pain. Okay. Lastly, meniscus tears and ligament injuries. So like I said earlier, this often happens in the setting of twisting injuries, usually during contact sports. I myself tore my ACL during a soccer game. And meniscus tears, okay, they are usually classified into whether they are complete or incomplete displays, whether it means to say whether it has moved position or hasn't moved position. It has moved position and it's complete. Typically, it will cause issues in terms of your movement and usually require surgery, usually keyhole surgery nowadays, to repair it or to excise it to remove the damaged meniscus. With regards to ligament tears, it also depends on age and the degree of dysfunction you have. Sometimes they require repair, reconstruction, depending on the severity of the tear, whether it's partial or complete, and whether you have instability. Instability meaning to say, for example, when you walk, your knee gives way or buckles, or when you want to do sports, you can't turn or you feel very unstable when you turn. So those are the indications where you may need to do surgery after you have tried a course of physiotherapy. So like I mentioned earlier, knee osteoarthritis is the most common cause, and I see most of the audience I have are should be above 45, not to generalize. So I think knee osteoarthritis is a very relevant topic for everybody here. Okay, it is in fact the most prevalent cause of knee pain, affecting almost 654 million people worldwide, and most common in the elderly. Okay, to break it down very simply, the word osteoarthritis essentially means degenerative joint inflammation. Okay, osteo meaning degenerative, arthro referring to the joint, and itis meaning inflammation. So although I mentioned earlier that osteoarthritis is mainly the result of wear and tear and loss of the cartilage, in fact, it's actually more complex than that. There are things like bone spur formation, swelling of the joint, you get swelling after you walk for a long time, swelling of the soft tissue, and the list goes on and on. So I saw some pictures over here. The picture on the top left shows a normal knee x-ray, and the picture on the top right shows an abnormal knee x-ray. Okay, so you can see the difference. The one on the left shows that there's good joint space, there's no increased bone growth, and there's no increased whitening of the surfaces of the bone, whereas on the other side, you can see that there's no more joint space. Okay, the cartilage is all worn out, there's increased bony growth, what we call the spurs, okay, as well as there's what we call sclerosis, or thickening or increased density of the bone because of abnormal loading. Okay, so this reduced joint space is due to loss of cartilage and meniscus degeneration. So at this point of time, you may be wondering, doctor, why me? Why do I get osteoarthritis? Why not my colleague? Why not my friend? How did my cartilage just well on its own? So to answer this question, one must understand that knee osteoarthritis can be broadly divided into two main types. Okay, primary and secondary. Primary osteoarthritis essentially is degeneration without any apparent or underlying reason. This means as doctors, we cannot identify any obvious pre-existing cause for your arthritis. Okay, and the most likely cause is due to two things: aging and some genetic predisposition. Okay, so it just sway cannot really help it. Okay, but this does not mean that there are no predisposing factors. So there are still risk factors, even though we can't really pinpoint it. Some of the risk factors that put you at higher risk are things like obesity. Okay, higher body mass index does put you at increased risk. Other things include things like gender. So for example, females, we know they are more common to get osteoarthritis. Number two, pre-existing knee alignment. If your knee is bent, what we call either knock knees or bow-legged, okay, you tend to get osteoarthritis as well because of the malalignment, or things like your hobbies or your occupation. So because marathon runners, they do a lot of running, they obviously wear out their knees faster, okay, compared to those who do not do so. On the other hand, secondary osteoarthritis is a consequence of a pre-existing knee injury that results in the abnormal concentration of forces across the joint. Okay, so for example, what I talked about earlier, like meniscus injury, or you have a cartilage injury in the past, all these were predisposed to you getting knee arthritis at an earlier age, okay, compared to the standard primary knee osteoarthritis. Another type of secondary osteoarthritis that's quite common in our age or in our population would be things like inflammatory conditions, okay, things like rheumatoid arthritis, things like even gout, okay, are also causes that can cause secondary osteoarthritis. But safe to say, majority of the osteoarthritis that you see or the joint pains that you experience as you age is due to degeneration, is due to primary osteoarthritis, and we can't really explain that beyond age and genetics. Okay, so osteoarthritis is typically a progressive disease that eventually leads to disability. Okay, common symptoms that you may experience: number one, knee pain. You get a lot of pain that it's gradual onset. A lot of people, they complain of pain when they first get up from a sitting position to a standing position. That's called startup pain. Very classical of osteoarthritis. Okay, it's usually worse with activity. So they say, I only can walk to my market, I cannot walk any further. Or pain after prolonged sitting and resting, and worsens over time. The type and the intensity of the clinical symptoms may vary for each individual, but they typically become more severe. Usually over time, they become more frequent and more debilitating as the X-ray usually is just a reflection. You can have a very bad X-ray but not so severe symptoms. But generally speaking, the more severe your X-ray looks, the more stiff your knee is, the more severe pain you'll get most of the time. Oh, okay. And then treatment of knee osteoarthritis begins with conservative methods and progresses to surgical treatment options when the conservative treatment fails. So I'll speed up a little bit. I have 5 minutes left, but I'll be talking about last three slides. Treatment options for knee osteoarthritis, as well as some frequently answered questions. So treatment for knee osteoarthritis, we can typically break it down to non-surgical and surgical treatment. Initial treatment begins with non-surgical treatment such as activity modification, exercise, physiotherapy, and all this we move on to surgery when the non-surgical treatment has been exhausted or no longer effective. Okay, so the non-surgical treatment are all written down there. I believe you can see it. I just want to read off activity modification, exercise, physiotherapy, weight loss, use of walking aids, orthotics, analgesia, supplements, and injections. Okay, so something as simple as just avoiding stair climbing or switching from running to cycling, running to cycling and swimming may just offload your joints a lot, because when you're running, you're putting a body weight a lot on your knees. When you're swimming or cycling, you're not doing so. Okay. Additionally, a combination of supervised exercises and home exercise program has shown a significant benefit for a lot of patients with knee pain. How does physiotherapy help? I'll leave it to physiotherapists to explain, but generally speaking, people ask me why I need to do physiotherapy. It helps to strengthen your muscles. What happens when you strengthen your muscles? You get more control of your joint. Okay, your joint pains is usually due to a bit of instability, and the physiotherapy combats that. Secondly, it treats your muscle spasm, and thirdly, improves your range of motion, and that helps in your activities of daily living as well. And like I said, this is also based on recommendations, and this is actually recommended by the American Academy of Orthopedic Surgeons. Okay, weight loss is valuable in all stages of knee osteoarthritis and is indicated in patients with BMI of greater than 25. And the best recommendation to achieve weight loss is a diet control and low impact aerobic exercise. Do knee braces work? Okay, so some patients can use an aid, like a knee brace, to offload the painful knee during during walking. For those with a bit of deformity, some people have tried what we call a valgus knee brace. That has not shown significant benefit. What has shown some benefit in terms of some aids is use of a walking stick. So whenever you put weight on your knee, you may have pain. So with use of walking stick, or in the Asian context, an umbrella, okay, that will help to offload the pain in your knee. Okay. The last two, analgesia, supplements and injections. So analgesia essentially is painkillers. It's the first line treatment for patients with symptomatic knee osteoarthritis. And there are many options, ranging from something very basic as paracetamol to something stronger like tramadol, which is a type of opioid. It's a type of it's like a subset of a variant of a cousin of morphine. Okay, a wide variety of other non-steroidal anti-inflammatories. For those who are suffering from osteoarthritis, you may know some of these names, things like Coxia, things like diclofenac. Okay, you may know some of these names as well. And choice should be based on three things: patient preference, your profile, as well as your risk. And the duration of treatment should be based on, your past medical history, how effective it is, and any adverse effects as well. So, like I said, going back to the recommendation, this is also recommended. So physiotherapy, painkillers are both recommended by the American Orthopedic Surgeon Society. Okay, the most common question that people ask: do glucosamine or chondroitin sulfate, these are supplements, do they work? Okay, they're available as dietary supplements, and they are structural components of articular cartilage. And the thought is that, the whole idea why they come out with this thing is that a supplement will aid in the health of the articular cartilage. However, no strong evidence currently exists for the use of these supplements and show that they are beneficial in knee osteoarthritis. So according to the guidelines that I mentioned, the two guidelines, they actually do not recommend supplements in the treatment of knee osteoarthritis. But I mean, in my own practice, I feel that there are no major downsides to taking the supplement. If you understand, or the patient understands that the evidence between these supplements are not strong, and they're still willing to try, it's a relatively safe option, and any benefit gained from supplementation may be a result of a placebo effect or some, but it's basically maybe patient dependent. Okay? Okay, lastly, injections. There are two types of injections that people normally get. One is a steroid injection, intra-articular corticosteroid injection. They may be useful for symptomatic knee osteoarthritis, especially when there's a considerable inflammatory component. And the delivery of the steroids into the knee joint helps to directly reduce the inflammation, okay, and minimize the systemic effects of the steroid. However, there are risks with this injection, such as infection, skin thinning, and initial more pain due to a flare. The last injection that many of us that can even be given in the GP setting that you may be familiar with is this thing called Synvis or hyaluronic acid injection. So the whole idea behind it, same as the oral intake of the supplement, instead of taking it orally, they try to inject it directly into your joint. Okay, so this hyaluronic acid is essentially it's a protein that's found inside the body, inside the joint fluid. So the whole idea of injecting it is to somewhat replace the fluid that you have lost so that you can regain it But unfortunately, this also has shown that it hasn't really benefited most patients. Okay, studies have shown that it's more placebo effect. I personally do give it if the patients have tried it before and it works, but I do not give it as a first line of treatment. Okay. So lastly, we go on to surgical treatment options. There are three things: knee arthroscopy, osteotomy, and replacement. Arthroscopy essentially is keyhole surgery where we clean out your knee joint. Safe to say, essentially, this is not the practice anymore. A study has shown in the past that this does not help in knee arthritis treatment and has been essentially scrapped unless you have a meniscus injury that is causing jamming of your knee and we need to take it out. Knee osteotomy is reserved for younger patients with malalignment of the knee. It can be useful to prevent you from getting a knee or reduce your chances of getting a knee replacement in future or delay it at least. Okay, but not commonly done. Knee replacement is the most common surgery. It's very effective, but I would say it's the last line. So you say after you have exhausted all your treatments on the left side and you're in severe pain, your X-ray looks this bad as the previous picture, and you can't really function in terms of your walking, your mobility, then knee replacement, I would say, is a good option. Okay, I think I've run out of time, so I would not go into detail about the rest. Okay, I will talk through my frequently asked questions later on during the Q&A. Is that okay? Yeah, because we've run out of time already.
Actually, you can still go on. I think until 4 minutes.
Oh. Okay, I don't want to rush, so if you want, I can continue now. And what do you think?
You continue.
Okay, can. Okay. Okay, so. Okay, can. Okay, so I given more time so I can continue asking, going through the frequently asked questions. So, I mean, this slide, essentially, which I skipped through quite briefly, this is the AAOS Clinical Practice Guidelines Summary, which some of the recommendations that we get most from so that we can align our practice towards. And this is the guidelines where it talks about what is the treatment modality on the left-hand side and whether it's recommended or not recommended. So you can see the main one in the middle is AAOS. It says hyaluronic acid, strongly not recommended. Okay? And things like NSAID, paracetamol, exercise, all these are strongly recommended. So, yeah. Okay, so frequently asked questions. Essentially, this segment is some of the questions I get asked by my patients in my clinic, and essentially it's try to debunk some of the myths, clarify some of the misconceptions regarding knee osteoarthritis. So these are my own personal experience. It may not be reflective of what y'all may be asking me later or of the general population or general public. Okay, so one of the most common questions I get is, why did I get arthritis, and can I cure it? Is it curable? So can I prevent it? Unfortunately, majority of patients I mentioned earlier have primary knee osteoarthritis, okay, and the cause may not be immediately clear apart from age, or maybe your family, your father, mother, or your sibling all have knee arthritis, and you also have it. Okay, so hence most of the time we as orthopedic surgeons do not have a good answer to the question, why me? As we do not know, we honestly do not know. But furthermore, a sad thing is also that arthritis is not curable. Once the degenerative process has started, there's no way to reverse it. Okay, at least in current medical practice, I'm not aware of any magic pill or magic surgical procedure that can make a 60-year-old knee become a 20-year-old knee. Okay, nothing in the market. We can't do miracles like what Jesus can do. Okay, but what we do know is there are many risk factors, like I mentioned earlier, that contribute to or accelerate this wear and tear process. And it will be prudent, it will be wise to tackle these factors to slow down the progression or reduce the risk of one getting symptomatic knee arthritis. So what are these methods? So lose weight, okay? Quit smoking if you smoke. Exercise to strengthen the muscles around the knee. All these three can help to prevent you from getting knee pain or prevent you from, if you have arthritis, it prevents it from getting worse even. Okay? The next thing is, the second question I always get is, does my diet affect my knee pain? Do I have to avoid certain foods like prawns lah or that lah? Some people, they say that they have to eat a certain way to prevent knee pain. Well, the good news for those fast food lovers is that no, diet has no bearing on knee osteoarthritis. Okay, what we eat does not accelerate nor decelerate the process of knee arthritis, but there are two caveats. Okay, the first is that one's body weight has a significant bearing, on your mechanical load on the knees. So naturally, if you have an unhealthy diet and you gain a lot of weight, then your diet will lead to you deteriorating your knee further. Okay, that's number one. And the second caveat is that in relation to secondary osteoarthritis, so one of the things that I mentioned earlier is things like gout or rheumatoid arthritis. Rheumatoid arthritis is not really related that much to food, but gout is. Okay, gout is a condition where you eat too much protein, drink too much alcohol, or take too much red meat. You can get flares of gout, okay, because you're unable to break down the protein so well in your body. So gout flares not only cause significant discomfort and disability, but over time they will lead to further knee degeneration and osteoarthritis because they destroy the cartilage. Okay. So on the topic of diet, a very frequently asked question is in relation to supplements, like I mentioned earlier. What supplements should I take? Is calcium good? Is glucosamine good? What about things like Ginflex? Okay, so the truth of the matter is there are a large variety of supplements available in the market, and all of them claim to be very effective super good. Take it 5 days, 10 days, you get better. 30 days, get better. But as mentioned earlier, there's no large, well-run clinical studies supporting their use. So the recommendation paper a lot of us use is the AOS guidelines, and they don't recommend the routine use of these supplements. However, although the evidence does not consistently demonstrate a benefit to these supplements, anecdotally, I have seen some patients myself with some benefit in terms of their symptoms improving with some of the dietary supplements. And given the risks involved are relatively minimal, I generally tell my patients that there's no harm in consuming these supplements, but you should not use this as a sole modality. It means that you cannot just take supplements but eat unhealthy, go and continue running a lot, don't modify your activity, don't go and do physiotherapy and expect to work. Okay, it doesn't work that way. It shouldn't supersede the other modalities of treatment, and you shouldn't have too high expectations of these supplements. Like you shouldn't take them and expect that your knee pain will fully disappear. They may help to a small or certain extent, the magnitude of which we are not sure. Okay. The next most common questions is about injections. So, do injections work? Which one is better? Is hyaluronic acid better? Is steroids better? Now, even the newer ones in the market called platelet-rich plasma. How often should we get these injections? So, these are very common questions. And injections do work. Some of them do work in a short-term period. So, currently, the best evidence that we have in terms of evidence means to say that they've done studies. One patient get this injection, the other patient get another injection, and they measure the pain score after 3 months. Okay, the one that works the best is the steroid injection. Okay, based on the studies, the best evidence we have is for steroid injections, and this is the only injection approved by the guidelines. The steroid injections work by steroids is essentially a drug that help to suppress your immune system. So they suppress the inflammation in the knee such that there's less destruction of the cartilage and less inflammation in terms of pain from swelling, pain from all the pain mediators activated, okay? But there's not without the drawbacks. When you do a steroid injection, there's a small risk of infection. Commonly, we quote about 1%. And there's some risk of sometimes the skin around it can become a bit thin, or sometimes they can increase pain initially because the steroid takes a few days to work. So that's why sometimes they accompany with a local anesthetic injection together with the steroid injection, okay? A new up-and-coming drug is the platelet-rich plasma, where they draw some blood out from your vein and then they spin it and they put it into your knee. It's a bit more expensive. Has it really shown to work? I would say in the studies that I've read, only certain cases. So it's not as gold standard as steroids, but to me, it's not significantly dangerous, but it hasn't shown much benefit as well. So I'll leave you all to be the judge for it. Okay, it's still new. So there's not much data on it. Some papers say that there's some benefits, papers say that there's not much benefit. So hard to say at this present moment. Same thing for the Synvis. So Synvis injections are very common, and I know some patients who go for monthly injections, okay, for their knee pain. So the theoretical benefit, I believe I went through already. They introduced the joint fluid into your joint, hyaluronic acid being a main component of it. And practically speaking, however, these injections have not shown any significant or long-lasting clinical benefit. I personally would say that there's no harm in going for an injection. If you feel it works, that's good. But to go for monthly frequent injections is a bit dangerous. Reason is mainly because number one, the cost is quite a bit okay, but it's $500 per injection or something. Number two, the more frequent you get injections, the higher chance of you getting infections with each injection. And a knee joint infection can be a very serious complication. So I would say maybe every 6 months if really necessary. Okay. The next two questions are regarding surgery. Okay, so when should I go for it and what should I expect? To be honest, the first question is a very personal one, as the need for surgery is ultimately dependent on the degree of disability and pain that you, the patient, feels. Okay, as doctors, we are taught about the various severity of knee osteoarthritis on X-ray, some from the very mild to the very bad ones on X-ray. The knee can be completely bent, but if the patient, is not having pain and not function limited, then we don't really offer surgery. So ultimately, it's the degree of pain and function limitation that makes the risk-benefit ratio worthwhile. As I always tell my patients, all surgery have risks, but the recommendation for surgery is always made when we doctors feel that the benefits of surgery outweigh the risk. Okay, in most cases, this is when patients have end-stage radiographic changes or osteoarthritis, and they also experience significant pain and disability affecting their activities of daily living and their hobbies after they have gone through a period of non-surgical treatment. So all knee osteoarthritis that I see, I always send them for a period of non-surgical treatment, which is things like physiotherapy, weight loss, painkillers, etc., etc., etc. Next thing, knee replacement surgery is very safe, it's very common. In fact, annually in the US, more than 700,000 is done, okay, and they have a complication rate of about 2 to 5%. Okay, majority of patients, we usually quote about 80 to 90% satisfaction rate, means 80 to 90% patients are satisfied after the surgery, and 90 to 95% of patients have good functioning prosthesis at 10 years post-surgery. So I would say arguably it's one of the most successful surgeries that in orthopedic surgery or even in any kind of surgeries in the world, okay, because it is very forgiving and such a high success rate. So usually 5 to 10%, there may be some complications, but for the 5 to 10%, it's very devastating. But generally, if you look at the averages, a lot of averages, this is a very successful surgery, a very safe surgery. Okay? What do you expect? What can I expect after surgery? The post-operative regime and the rehab is different among surgeons, okay? But most patients can be discharged within a week. Barring any complications, the wound heals in 2 weeks, pain and swelling subsides in 6 weeks, and the knee starts to return to normal in 3 to 6 months, okay? The key thing is rehab, which is what my colleague Nicodemus does, and they help these patients post-knee replacement surgery to get back to their mobility by asking them to do exercises, optimizing their health around it, and doing range of motion training. Okay? So that's all I have for you today. I'll be back later to answer some questions, but I hope this talk has been useful, and hope you have learned much about knee pain, the causes, and the various treatment options for knee osteoarthritis. Thank you.
Thank you very much, Joel. We will now have a 10 minutes break. Do help yourself to the snacks at the back in the kitchen, and as well as the slips of paper for writing your questions for the Q&A. So now it's 10:58, so please be back promptly by 11:08. Okay. Okay, 11:10. Okay, sorry. 11:10 then. Thank you very much. Hi, good morning, everyone. We'll be starting soon. Please settle down, and if you have any questions, you can feel free to pass them to me now, or later you can raise up your hand during the Q&A. Hey, good morning, everyone. Welcome back to our third and final talk. I'm pleased to introduce our special guest speaker, Ms. Kelly Chew. Kelly graduated from Nanyang Polytechnic with a diploma in physiotherapy and subsequently a Bachelor of Science Physiotherapy from Trinity College Dublin in 2019. She currently works as a physiotherapist in Physio Connections Clinic in Novena Specialist Centre, and I have personally benefited from her help and expertise. Apart from having experience in helping patients with musculoskeletal and cardiopulmonary issues, she's also a qualified lactation consultant, certified breastfeeding specialist, and spearheads the Women's Health Physiotherapy Service, running antenatal and postnatal programs. We look forward to hearing her share practical advice with us on the topic of neck and knee pain management.
Okay, so good morning, everyone. So today I'll just be talking very briefly through the neck and knee pain, but more on the management of them. Okay, so usually why neck pain? Okay, because nowadays with more desk-bound jobs, we are getting more neck pains. So it's becoming more and more common. And even for people without work, who is not working a desk-bound job, they are moving around. What happens is we always take our phone, and then you always see, they always look at their phone and then they walk. So what happens, we always do this, and then we walk everywhere. Okay, so it becomes very dangerous for people around you because you are not very aware, that's one. But on the second part, it also actually hurts your neck. So what we need to do is to actually stop this habit, okay, and also help you with managing all your neck pain that you may have. Okay, so knee pain. So usually for osteoarthritis, right, that was shared, you will get it on one leg first, okay? But by the time you go and see a doctor, you go and see a physio, the leg that started first may not be the most painful one that you have at that point of time. It may be the opposite, most likely, okay? Because when, example, you have your leg pain starting on your left leg, okay? Subconsciously, what our body will tell us is shift your weight onto your right leg. So you offload your left leg a little bit. And then what happens over the long run, right? You actually overload your right leg. So by the time you go and see a doctor, you'll tell them, oh, doctor, I got both leg pain. Okay, but which one start first? The less painful one. Okay? So usually this is some common things that I tend to see in the clinic when they come in with knee pains lah. So usually what we need to do is to really strengthen up your muscles, make sure that it doesn't get worse, and also make sure that you try and shift your weight back more towards the center and getting our posture correct as well. Okay, so common things that we will do before we even seek treatment lah. So first thing, when you got neck pain, you got back pain, you got knee pain, actually wherever you got pain, right, first option you will do, most people, they will just go and buy the deep heat. They will put deep heat, they will put plaster, they will put koyo. Correct or not? Most of the time. I think most people will do that first before they even do any other things. Okay, then if it fails, may consider just taking Panadol, painkillers. Any painkiller you can get off the shelf or any painkillers that you have at home. Usually we'll have one cupboard of a small stash of medications at the house, okay? So this is what we will tend to reach out for first thing, okay? And then maybe some people, they will consider neck or knee supports. If it happens over a long period of time, they may consider getting a neck support or a knee support. But actually all this support, good if you are using it just for short term, but if you are using it long term and for long duration throughout the day, it actually can cause you weakening of your muscle. So it actually may not be as good as you imagine it to be. Okay, and then for a lot of Chinese, right, what we tend to do, we go see TCM. Okay, they go twin, they go acupuncture. Okay, how I know? Because my mom does the same thing lah. Knee pain, don't see me. Rather, I go see doctor already, sprain knee, okay, never mind, I go see TCM, I go do twin, I go do acupuncture, but I refuse to see physio. Okay, very common one, so it's normal, don't worry. Okay, so really last resort already, no choice, pain, see TCM, see do twin, take painkiller, see everyone doesn't help. Then what they do, they go see doctor, okay? See doctor already referred for physio, then okay lah, they go come physio 1 or 2 sessions, see if it does work for them, okay? So this is what are the common thought process when we have pain. First reaction until really bo pian come and see physio. Okay, so what do physiotherapy do in general? Most of us, we do joint mobilization, joint manipulations, we do traction, but for our clinic, we don't use the traction machine very big. What we do is we do more manual because we don't really use traction that often. Okay, then other things can be heat pack, cold pack. Then interferential current therapy is more of using currents to actually help reducing the pain that you feel. Soft tissue mobilization, very, very different from massage. Okay, because I think another misconception that people have is that physio, we are masseuse. We are not masseuse. We don't do massage for people, okay? And then other things that we will do or we can do for you is to teach you how to stretch, correct your office ergonomics, correct your posture, and also teaching you proper strengthening exercises that is based on your condition. So you may have this condition, your friend may have the exact same condition, but the two of you come to the clinic, you may have different exercises when you all go home. Okay, it is really dependent on what is your, how you are at that point of time, which muscles we need to train for you, which muscles for you is tighter, so you may go back even with different exercises, even though both of you may have the same condition. Okay, so for office ergonomics, like what just Dr. Nicodemus was mentioning, okay, you need to make sure you sit straight. Okay, but one thing also, the thing you are leaning on right now is called a backrest for a reason, because you're supposed to rest your back on it. Okay, so most of the time when you work on a computer, I think 90% of us, we sit initially very good, we lean on the back. After maybe half an hour, 1 hour, or a couple of hours later, we start to peel ourselves off. And then we'll start leaning closer and closer towards the computer. Very common, okay? So what we need to remember is this is called a backrest because you are supposed to rest your back on it. So please don't peel yourself off, and make sure when you sit all the way in. Don't leave a gap in between the chair and your buttock. Okay? And then make sure that you try and elevate the height of your computer. If you are using a laptop, very difficult to bring your laptop up to your eye level, what you can consider is two things. Either you get an external monitor or you get an extra keyboard. Okay, so you either lift your laptop up, use an additional mouse and keyboard to control your computer, or you just use an external monitor, you just bring your monitor up. So that's the two easier ways. But of course, the more cost-effective one is just get a keyboard and just lift your laptop up so that you can actually don't need to always look down and use your computer all the time. Okay? And then when you are working, you need to remember the red shaded region is not very accessible. So when you try to access that area, you have to reach. Means you have to move forward, lean forward. And then most of the time, what happens after that, right? We don't sit properly. We start to lean forward when we use our computer. So try to put all the things that you need or you expect you will need in the white area, closer to you, within arm's reach, so that you can actually make sure that you don't change your posture so often. Okay? And then make sure you position your monitor right in front of you and your keyboard is not too far, so you don't do this when you type. Okay, because this will also cause your shoulder or your neck to be strained as well. Okay, so simple stretches that you may want to do. Okay, just remember a point of note. Hold all your stretches for at least 15 to 20 seconds. Okay, anything lesser than 15-20 seconds or not very effective. Okay, but anything more than 30 seconds, not much additional benefit, so don't need to waste time. Okay, and then you need to repeat all your stretches at least 4 times. So if, example, we are doing it a neck exercise, we do left side, right side, this is considered once, not 2. Okay, and then you try, especially for desk-bound job workers, you try to do your stretches at least once every hour, neck stretches. All those leg stretches and everything, you at least do about 2 times a day. Once in the morning before you go to work, once at night before you go to bed. Easier for you. Okay, so for simple stretches, let me just show you. This is for the side of your neck. You all can actually try it now. Okay, so what you do, right? Oops. Okay. Oh no. Okay, you make sure you tuck your one hand. You either stabilize it holding the chair or you sit on your hand. Okay, I think this one a bit fast. Hang on. Okay, so you should feel the pull at the side. Okay, so basically what you do, you sit one hand, okay, or you can hold on to the chair. Bring your opposite ear to your opposite shoulder. Okay, use your hand, the opposite hand, pull. Okay, so you feel the stretch here, this side. So your hand is here, on your head. Okay, so the purpose of fixing your one hand, right, is to make sure you don't do this. You are stretching the neck, not the back. Okay, so you just stabilize one side and pull. Okay, even if your ear cannot touch the shoulder, doesn't matter. Okay, then you change side. Okay, you should feel more at the side of your neck. Can? Okay, you want more effective, you sit on your hand. If not, you can always just hold on to the side of your chair. Then you stabilize that one side. And then your shoulders will not move. Okay? Okay. The next one looks quite similar to the first one. Also sit on one hand. Okay? But just now bring ear to shoulder, right? Now different. Now bring your nose to your armpit. So like that. Like that. Okay, now you will feel the neck, the stretch actually goes back a little bit. It's not so much at the sides anymore. Okay, I'll show you the videos. Okay, so you turn about 45 degrees downwards lah. Okay, so just now it's like that, correct? Now you turn a little bit and then you look down. Okay, so same thing lah, it's just the angle is a little bit different. Now we are stretching a different muscles already. So this one also same thing, must do for both sides. We cannot only do one side, if not later imbalance also you will have problems. Okay. And then the next one will be calf stretches. This one, of course, very easy if you do it in standing lah. So what I can show you, you find yourself a wall. Okay, one leg in front, one leg behind. You start to make sure you keep your back leg straight. Okay, then you lean yourself forward a little bit. Okay, then you should feel a pull near your calf. Then you should feel a pull at your calf. Okay, so point both toes forward so you don't turn your feet like that. It's all like that. Okay, so you same thing. All the stretches hold for about 15 to 20 seconds. Okay, and then the next one also in standing is to stretch the front of your thigh. This one is called a quadricep stretch. So actually all these videos, right, you can just go on to my company website, or we all have the links from there. So no need to worry taking videos. Understand the concept first, easier. Okay, so for quadricep stretch, you stand supported. Okay, then you bring your opposite one of your leg to your butt. Okay, you should feel a pull at the front of your thigh. Hold the stretch. That's all. Okay, and then you change leg lah. So also same thing lor. Remember, all this need to do for both sides. Cannot always do only one side. Even if you tell me, I only got one leg pain, my other leg not pain, do I need to stretch? Answer is yes. Because when we sit for long hours, our muscles will still get tightened. It doesn't matter, only left leg pain, right leg not painful, but both your left and your right leg, your muscles will be evenly tight. Okay, so you still need to stretch. Okay, and then this one is to stretch the side of our thigh. So this one is a very, very tight band for most people, especially runners who don't stretch. Okay? So this one, what you do, you find yourself a wall, you cross your leg. Okay? Doesn't matter which leg first, because you need to do both legs anyway. Okay, then you lean. Okay, you should feel a pull at the side of your leg. Okay? Hold a stretch before you come up. So for those who you bend down very long time, you feel giddy, right? Then we can always change this stretch a little bit, or we can forgo this first. Okay, but you should still be doing all your other stretches. Okay? And then the next one is your hamstring stretch, to make sure you stretch the back of your leg. Back of your thigh lah, this one. Okay, so this one is sit with your leg straight. Okay, bend one leg, and then you lean forward. It's like a sit and reach, one leg sit and reach. Okay, doesn't matter if you cannot reach your toes, but you should feel the pull at the back of your thigh. Okay, then you hold the stretch. Okay, and then you can change leg after that. Okay, so remember, all stretches must do both sides, because we are not one-sided, we are both two-sided. Okay? Okay, then that's all for stretches. One word of caution, I do have people who come in to me when I tell them you need to hold 20 seconds, do 4 times or 5 times. What they do, they do one side, They hold for 120 seconds. Does it work the same way? No, it doesn't. Okay? So try not to cut corners. When I say 4 to 5 times, even if you tell me I hold there 1 minute, the duration is the same, the effect is different. Okay? So after every repetition of your stretch, you need to get up. Okay? So that your muscles can realize that, okay, you are just stretching. Okay? You don't hold there for 1 minute, 2 minutes, 10 minutes. No additional benefit. Your muscles tight, still tight on. It's equal to 1 rep only, so not much difference. Okay? So what you need to do is to do about 4 to 5 reps for all the exercises, or all your stretches. Okay? Then the next one is more for strengthening exercises. We'll start off with your neck your neck muscles. Okay? So what you do, you tuck your chin in. Okay? So this one movement very small. So if you see from the front, not much movement. If I'm doing just like that, you cannot really see anything, right? What you do, you see from the side. So usually what we do, we have to look down more often. Okay? So what I want you to do is to look straight. Don't look down, don't look up. It's different. Okay? You look straight, eye level. You tuck your chin in. So you are like pulling your ears back towards your shoulders. That's all. Okay, so this finger is just a guide, it's not to push your chin in, it doesn't work. Okay, so it's just guiding, bringing your head backwards. So you are using the muscles at your neck. Okay, so one word of caution, I've seen a lot of people, they do like that. Tuck chin in. Does this work? It doesn't. Still need to look. So you keep your eye focused on one point, and then you just draw your neck back. Okay? So this one you can hold for about 5 seconds. Do about 5 to 10 times. All these seated ones easier to do, so you all can do even at work when you're outside, especially those smaller movement ones. Then it can still be fairly discreet even when you do it outside. Okay? So just hold the position before you relax. Okay, the next one, you need a bed. So you need to be lying face down. So this one, you do about twice a day, 3 times a day. If you're working from home, if you have a little bit more time at home, you can always do 3 times, no problems. Okay, this is called a Fink's exercise. It trains the muscles at your neck as well as your back. Okay, so what you do, you lie face down, hands up. Okay, then what you do is you try and squeeze the muscles here. Okay, and then you draw your chin up. So it's like what we did just now, just tucking in. But then now we are just tucking it in. Don't need to lift up your head. So it's just tuck in and then draw your shoulder blade close together. It's just like squeezing your 2 shoulder blades towards each other. Okay, then you can lift your hands gently off the bed for a short while and then you can relax. So it's not drawing your back up this way. It's just at the shoulder blades and at your head only, that's all. Okay, and then you just draw back, that's all. So very, very small movement, all this. Okay. And then the next one looks quite similar. It's a scapular retraction exercise. Just now that one you lie face down. This one you can do in sitting. Just now that one is you are squeezing your shoulder blades towards each other. Okay, now you are squeezing it slightly downwards in a V-shaped movement. Okay, so what you do, you see normally we slouch. So you pull your shoulders back in a downward V-shaped movement, hold for about 5 seconds. It helps to open up your chest a little bit as well, because we sit like that most of the time. Okay, so just tuck in and hold the position. Okay? Okay, then the next one, sit to stand. So those who already have knee pain, very severe until you cannot stand, you can always hold on to something. Okay? But those who are just looking to strengthen up your muscles, you can all do sit to stand. Fairly easy, you can do it anywhere. As long as you have a place to sit, you can do it already. So what you need to remember is when you are doing sit to stand, you need to use your buttock muscles. We don't only rely on our legs. Our buttock muscle is also a very big muscle that can actually help you absorb a lot of the load when you are trying to stand, when you are trying to climb stairs, when you are trying to walk. But what we do is we forgo our buttock muscles, and now we all rely on the leg muscles, and then where will the load all go? It will all go down towards the knee, towards the ankle, and then you will get a lot of stiffness, a lot of weakness that you will feel. Okay, so for sit to stand, what you need is just a chair. Make sure you don't sit. Okay, just now I mentioned you need to sit all the way towards the back, right? But for sit to stand, when you are doing the exercises, or when you're just trying to stand up from a seated posture, okay, you need to shift yourself out. The larger surface area of contact you have with the chair, right, it will make it even harder for you to stand. Okay, so shift yourself out, at least half the chair distance. Okay, and then you push up with your buttocks and your thigh muscles. Okay, and then when you sit down, try to sit slow. I know a lot of times when we do this exercise, right, you stand up, okay, very fast. Then when you sit, because of pain, because of weakness, you don't sit down slow. You just and drop down. Correct or not? A lot of times when we sit, you will hear the chair very loud one. Okay, so I don't want the sound. When you try to do sit to stand as an exercise, or even normally when you day in, day out, you are standing up, you are going somewhere, you want to sit down on a chair, try to do it slow. The slower you do, right, the more muscle control you will need. And in the long run, it does help with your muscle strengthening a little bit. If you don't do it as an exercise, just as a day in, day out thing. It helps to reduce the chance of the likelihood of your muscles getting weak even faster. Because once we hit age of 30, we all start to lose muscle strength already. I think here most of us, we are all above 30 already. So when you hit 30, you already start losing muscle strength. What's more when we age even further? Okay, so this is something that we need to make sure that we start to train up a little bit earlier. So don't think that I'm still very young. I'm 20s, I'm 30s. You're already starting to lose a bit of strength already. So better to start training earlier than later. Okay, then the next one is step ups. Those with already have a very, very severe knee pains when you climb stairs, then please do this with caution. Okay, so for step ups and downs, what you do, you step up using your thigh and your bum muscles. Remember, always must use your buttock muscles. Okay, and then try not to do step downs from the front if you already have knee pain. You just do up and then come back down from the back. You don't go down from the front. Okay? Okay, so what you need to remember is a stretch every hour helps to keep your pain away. So remember to stretch, correct your posture. Sitting posture, standing posture are very important, because if we always keep ourselves stuck in a very bad posture, right? High chances of your muscles weakening is one. Another thing is high chances of your muscles tightening is another one. So that's why you need to stretch every hour, because nowadays with all the technology advancement, even more so that now there's a lot of us working from home. So instead of last time I have to go out, I still walk out from the house, I walk to my car, I walk to the public transport. Now what we do, we just caught ourselves locked out in the house. We don't even go anywhere. You need food, you can get delivery. You need groceries, you can get delivery. Everything gets delivered to your doorstep. You don't even need to step out of your house. Okay, it means that we are losing a lot of exercise, a lot of movement from our bodies. So what we need to do is to make sure we keep our exercises up and make sure you stretch often. Okay? Okay, that's all I have for today.
Thank you very much, Kelly. Now we will be going into our Q&A segment. I have some sets of paper that you all have passed to me, but if you want, you can wave your slip of paper in the air and I'll come to you, or if not, you can just raise your hand directly and you can say your question. So I have some questions here already. I'll just start with, because Nicodemus, he had to go off earlier to see some patients. He'll try to come back later. So those with regards to neck pain, I'll probably skip for now. So I'll just go into those that Joel and Kelly will be able to answer. Okay. So will steroid injection to knee further damage the knee joints in the long run? So maybe Joel can answer that.
Like I said earlier, the frequency of injections matters. So I think a single shot steroid injection should not damage the knee in the long run. However, if frequent steroid injections resulting in infection, that will definitely damage the knee in the long run. So with regards to the contents of the injection and whether the contents cause any significant downside, I think a single shot, if it's approved by the AAOS, it shouldn't have too much issues. But if you're going for it every month, then that's definitely not recommended and may have long-lasting damage. Maybe I just stay here.
This one also.
Oh, okay.
Maybe just the first one. The other one
Okay.
is neck.
Oh, okay. Okay. I mean, I can answer. Okay, lah.
I mean,
Yeah. So there are two questions here. I'll answer the one related to the knee. So this person had a knee replacement operation coming to 2 years, and he has some sensation over his shin area, off and on. Is this normal, and what is the cause? So generally speaking, knee replacement surgery, essentially what we aim to do is to remove all the damaged bone and cartilage and replace it with a metal piece. Okay, so this metal piece is commonly made out of cobalt chrome lah. Okay, with the thing in the middle made of a type of plastic called polyethylene. You will feel that your joint is not 100% normal. That is to be expected because your joint is not your native joint. I think the sensation is a bit vague here. The word sensation is a bit vague here. In the sense, you will probably feel that your knee is not, doesn't feel like your native knee. That is to be expected, but you shouldn't feel pain. If you feel pain or if you have swelling over your knee or discomfort after walking, then that's not a good sign. You need to see your surgeon who did a knee replacement. Perhaps it could be signs of infection, perhaps signs of loosening, perhaps signs of malalignment or things like that. Another thing that is common after knee replacement surgery is maybe you feel that there's some discomfort with your scar or a little bit of numbness around your scar. That is also normal. So why? Is because there are small skin nerves around the knee joint. They cross from outside to inside. So outer part of the knee to inner part of the knee. So when you cut, you invariably cut some of these nerves. So if let's say you're feeling the sensation that you're talking about is some numbness around the scar, that is also to be expected. That can return with some time, but if it's already at 2 years and it hasn't come back, then it may be permanent. Usually, most patients are quite tolerate this quite well because ultimately, like I said, all surgery carries some risks. These are the very minor ones, and the surgery usually done when you have experiencing significant pain beforehand already. So, if you're referring to this kind of sensation, then I think those are normal. But if you're experiencing pain, swelling, discomfort, or even things like disability, then definitely you should see your surgeon.
Okay, I have two other written questions here, which I'll direct to Kelly. So this question is the pain at the bottom of the sole related to knee pain? And there's another one here that the person says, when I cycle and at times I feel a bit of discomfort at my left knee, but it goes away after a while. Should I still continue to cycle? Yeah.
Okay, so with regards to the first question, right, the pain at the bottom of your sole is usually not related to knee pain. Chances are you might have plantar fasciitis or you might have other issues that is causing you pain at the sole of your foot, okay? So this one, good to have it checked out. Or what you can do is to make sure you try and stretch your calf first. So one of the stretches that I showed just now was a calf stretch. Try to do a calf stretch, see if it does help. Because sometimes if your calf is too tight, it actually affects the way you stand, the way you walk and everything. And also sometimes some of us, we do have flat foot, okay? Not sure if y'all do notice, but some of us do have flat foot, means this is the normal arch of our feet, right? Normal when you sit is normal, but then for some, when you stand, it actually goes down flat. Okay, this may cause unwanted strain at the bottom of your foot, and it may cause plantar fasciitis as well. So good to have it checked out. If it's very long, it has been there for a very, very long time. Okay, and then for question 2, when you cycle and sometimes you feel a bit of pain, so the pain comes and go. What may have happened is that your muscles may not be able to tolerate more than 30 minutes or less than 30 minutes when you start to move a little bit longer. If it is not there throughout, chances are your muscles just don't have the endurance. So when you want to go for a cycle, you want to go for long walks, just remember, give yourself breaks in between. Make sure you take rest breaks. Stop before the pain comes. Don't stop only when the pain comes. So example, okay, when I cycle 30 minutes or 25 minutes, the pain will come. You stop and you rest. You should still continue to exercise, okay, as long as the pain is not crippling, it's not disabling. You can still continue to exercise. You can still continue to cycle if that's what you like to do. Just stop before the pain comes. So the pain comes 25 minutes, you can stop, say 20, 22 minutes, have a small break, maybe a 2-3 minutes break, and then you continue. Otherwise, what you can do is you can either slow down your pace when you cycle, when you walk, or sometimes when the pain comes. Slow down the pace of doing your exercises, slowly increase. So what we need to remember, although I'm trying to advocate all of you to do your exercise, please do not go from 0 to hero, because you will fail. Okay, nobody will go from a 0 to a hero in one day. Okay, so when you start training up, make sure you do it in phases. You don't start from totally not exercising to exercise 2 hours a day. Confirm after day 1, day 2, right? Day 3, day 4 onwards, you sure have a lot of muscle ache. And then you will start scolding, this Kelly tell me to do exercise. Then now I got all these pains, so uncomfortable, okay? So what you do is you slowly increase. So for example, you never do anything in your life, okay? Never mind, we start off slow. It can be even as little as 5 to 10 minutes, okay? Don't need to go run 1 hour, 2 hours, come back. Okay, we just need to do 5 to 10 minutes. Try out for a few days. Feel the difference in your body. And then after maybe about a couple of days to maybe a week, when you feel more comfortable doing this 5 to 10 minutes already, you increase 10% only, not more than 10%. Okay, because I know some people just double up. It doesn't work that way. It feels very slow to start up. Okay, so you just slowly increase, feel comfortable with the increase, and then you continue to increase only after you feel comfortable. Because our body is not meant to go 0 like machines. 0, you step like your car. You don't 0 step accelerator, it shoot off. Okay, it will slowly accelerate. So same thing for our body as well. We need to increase our activity level, our endurance, our muscle strength gradually. It will never go like that one. Okay, it will go slow. Okay, so just give your body a bit more time and give yourself a little bit more time to do exercises. Okay?
Any more questions? Oh, okay. Although Nicodemus isn't here, Joel, he said he's happy to also help take some of the neck questions. So I have some here with me. Okay, there are recommendations online about sleeping without a pillow as it allows the body to rest in a natural position. Will you recommend that, and will it help with neck pain?
Sorry, can I get
Oh, yes.
Yeah,
Actually, no, that was from my phone.
Oh, okay. So I think that's a very personal question. Everybody sleeps a bit differently. Some people sleep on their side, some people sleep on their front, some people sleep on their back. I think ultimately, like what Nicodemus said in his slide, right? There's no magic pillow that can solve everybody's neck woes. I would say do what is most comfortable for you. If you think sleeping without a pillow and you feel comfortable the next day, then please go ahead. I don't think it makes much difference lah in the larger scheme of things. So yeah. Okay. Try magnetic fields to activate muscle mitochondria. Okay, sorry, this is quite a long question. Let me just slowly read it out. So this person has tried some magnetic fields in Alexandra Hospital to activate muscle mitochondria of the knee. And this is not to be a kind of treatment. Not sure what this question here is, but the second question is, ankle replacement should be safe in this stage of my life, 70 years, if I still can walk but not able to walk long distances. At present, she doesn't do so. Whether she should go for ankle replacement? She also has a compressed spinal fracture L1, L2, and can I have a replacement? But the risk beside infection may also be shorter in the leg. True or false? Okay. So I think the second question is essentially about ankle replacements lah. Ankle replacements actually quite different from knee replacements. A few things. Number one, ankle replacements in the market, at least in Singapore, is not so commonly done. Reason being, it's a manufacturing thing lah. So the manufacturers haven't brought in the various types of implants that are available overseas to Singapore because the load is not so high compared to overseas. It's not as common as knee arthritis. So knee arthritis, like I said, a lot of them are primary knee arthritis, means we don't know what's the cause, just genetic and OH. Most people, genetics and OH, do not cause ankle arthritis. Most people get ankle arthritis either from a few reasons, most commonly being a previous ankle fracture. Others include previous cartilage injuries or previous ligament injuries to the ankle. So that's why the ankle replacement surgery as a whole is lagging behind knee replacement surgery. And even worldwide, the survivorship of ankle replacement surgery is not as good as knee replacement. Knee replacement easily quote 95 to 98% lah. Okay, for those big centers, the survivorship means, let's say I do a knee replacement for you, in 10 years, I expect it to be still well functioning. For ankle replacement, that number drops to about 80%. So 80%, 10 years later, you may need a replacement. A revision of your ankle replacement. Okay, because the longevity of ankle replacement is not so good. Okay, that's one. So generally speaking, we do ankle replacement at older age group. 70, if you're medically fit, actually is a good time to do ankle replacement. The other thing about ankle arthritis is that for the knee joint, the main option is a replacement lah. A replacement means to say that we change, like I said earlier, change the damaged parts to metal and plastic. For ankle, actually, there's an option of fusion. Fusion meaning we make the two bones into one. So your ankle doesn't move anymore, but most people can still function with that. Some soccer players have gone back to play soccer even after ankle fusion. So that's why the ankle replacement also hasn't taken off. So I would suggest to this person, ankle replacement, ankle fusion, do have a frank and open discussion with your surgeon. In terms of your age, it's suitable, okay? But in terms of the cost, in Singapore, it's very costly for ankle replacement because it's not fully subsidized. I think knee replacement probably about 5 to 10K, ankle replacement can go up to 20K, okay? So that's also one issue. The presence of a spinal fracture doesn't influence or doesn't prevent you or prohibit you from getting an ankle replacement surgery. Infection is a risk because wounds around the ankle have the blood supply is not as good as around the knee, so they don't heal so well. So if patients with like diabetes or you have on steroids for various reasons, then ankle replacement may not be the best option. Possible, but you just have to be careful. If you want to preserve mobility, that's still an option out there. But the risk goes up with certain conditions. So that is have to have a frank and open discussion with your surgeon. With regards to being a bit shorter in the leg, I think usually we can preserve limb length with ankle replacement surgery. I'm not so sure what's the first question, so if the person was asking this, if anything want to clarify offline, can do so.
Therapy, whereby Alexandra has been practicing and a lot of patients
I think that may be falling maybe in more Kelly's territory. So there's a lot of ways that like what we call alternative therapies. For example, ultrasound, massage, electromagnetic stimulation. Maybe Kelly, you want to?
Sounds like the biceps machine that NUH does use. That's one.
Yeah. So I'll leave it to Kelly to tell you.
Okay, so that one is from what I know, like sounds like a biceps machine whereby, from what I recall, NUH does use for some of the clients. It's supposed to use the wave to help strengthen up and regenerate some of your muscles, get your muscles strengthened. But truthfully speaking, if you ask me for a personal take, right, exercise is definitely still better lah. Unless you are really very, very difficult to do all your exercises because of pain, because of a lot of other medical conditions, right, then yes, that may help. I do have some of my clients who have used that biceps machine before. I'm not sure if it's a placebo effect for some. Some tell me that it works very well, okay? Because what you do is even if you have a left leg pain, you don't even need to put your left leg in. You just need to put your right leg in, okay? For about, I think it's about 10 minutes only. Yeah, it's about 10 minutes. So I personally have not seen through the whole therapy because I think it was about 12 sessions for one package lah. So I do not know exactly how well it will benefit you. You can try. I heard it's about 50 or don't know how much it costs per session lah. But personal take lah, if you can still manage with the pain or the discomfort, right, you can still always just do exercise lor. Less invasive also, cheaper also. Okay, then 3 more questions. Okay, so I have some pain on the elbow area on my right. Any connections with neck muscles on pain? So elbow pain really depends. It can be due to what we call as a golfer's elbow, tennis elbow, or it can be due to a referred pain from the neck. So it really have to check and then we can see if it does come from the neck, or if you already have neck pain and then you slowly notice that it actually goes down the arm and then it spreads to the elbow, or it's just a pure elbow pain. Okay, so this one must check, then we can know lah. Very hard to say out like that because everybody is very different. Okay, so for knee pain, the next question. I have stabbing pain as I step downstairs, probably due to wear of cartilage. What exercise can help to strengthen my leg muscles? And don't take supplements, have osteoporosis, and only take calcium tablet once a day. Okay, so even if you have osteoporosis, general strengthening exercises without weights, it's okay. So what you do is you use your own body weight, okay, as the weight that you are going to do all your exercises. So the exercises that I've showed just now, or the sit to stands, your step-ups, or you are using just your body weight, so you can still do. If you want, there's actually a few more videos on all the exercises on my company website, which if you all want later, I can share with you all. Okay, you all can just go to my website, you just click into the videos. All the exercises are clustered already. So we have leg exercises, we have for the knee exercises, we have for the back, we have for the neck and the shoulder. So all classified one. So don't need to worry. You can just click and it will link you out to the YouTube to check on the exercises. Okay. So anyway, most of the exercises that I showed just now also there. So if you all didn't catch the exercise, can feel free to just go onto the website and take a look after today. Okay. And then Then other exercises that you can do, right, especially for people with knee pain, okay, even if you don't have osteoporosis, what you can do is you can try walking in the swimming pool. Okay, so doesn't matter you know how to swim or you don't know how to swim. Okay, even better if you don't know how to swim because you will attempt to swim. Okay, so what you need to do, go to any swimming pool, any public swimming pool or any private pool that you all have. Make sure the height of the pool are not too deep lah. So about 1 meter to 1.2 meters. Generally, it will be about waist to about chest height, depending on how tall, how short you are. Okay. So what you do inside the pool, you just walk. Okay, simple enough, and just walk. Okay, walk forward, walk backwards, and then walk sideways, both sides. Not only one side, must walk both sides. Okay, so you can just do like maybe 5 minutes, 10 minutes of walking. Why inside the pool? Because if you already have knee pain, walking inside the pool, the upthrust of the water will help you feel less heavy on your legs. Okay, so it does reduce the weight that you put on your knees when you walk inside the water. And second thing, water got resistance. Water resistance is higher than air resistance, so you will feel more tired walking inside the pool. Okay, so I don't need you to do it for hours at a time. You just need to do maybe 1-2 rounds per direction. Okay, but if you're doing on weekends, just be a bit more mindful lah, because that depth is usually where kids will go and play. And then, you know, when they play, they run, they splash water, you walk halfway, then they knock into you. So just be a bit more careful only when you try to do it over weekends. Okay, and then last question, I have ankle swelling after walking up. Why? Okay, so ankles, generally for most people, our ankles will swell, or more so our feet will swell towards the end of the day. Okay, this is because gravity always pulls the blood downwards. Okay, so quite common. So what you can do if you have other medical conditions, diabetes, sometimes, or if your muscles are not very strong, right, what you can do is to try and sit and then elevate your legs up. Okay, if it doesn't go down very much, then what you do is you just do ankle pumps. So ankle, so you sit like that, right? Both legs up. What you do is just move your ankles.
Just want to add that if you have persistent ankle swelling, then it may not be normal. There are a lot of conditions that cause it, like varicose veins, or even heart or kidney conditions that predispose to ankle swelling. So you may need to see a GP to assess that lah. Definitely, generally speaking, most people's ankles will get swollen at the end of the day, but yours is abnormally swollen, or you notice it's asymmetrical, then you should see someone about it. Okay.
Thank you very much, speakers, for addressing the questions. We have now come to the end of our event. Before we close, we would like to ask our elder, Brother Michael Yeo, to present tokens of appreciation to our speakers. So Nicodemus is not here, but for our second speaker, Dr. Joel. Oh, wait. And also Ms. Kelly. Okay, thanks, Brother Mike. So one last thing before you all leave, we would greatly appreciate your feedback regarding this event. Please scan this QR code to share your feedback and comments for us to also plan future health events. We would also like to invite our visitors to our church services and programs. Okay, then you can go back to the QR code. So please feel free to approach any of our members if you require any assistance. Thank you very much and have a great day ahead.